Introduction to Nursing Concepts, Infection Control Unit, Part 2. Nosocomial infections are also called a hospital-acquired or healthcare-associated infection. They have several names. They mean the same thing. I go to the hospital and I get an infection while I'm there. Clients in healthcare settings, especially acute care hospitals and long-term care facilities, are at higher risk for infection than clients that we see in other settings, especially the home care setting. That's why we're seeing a huge shift away from the hospitals and more home care settings, because people are within their own environment and they aren't getting infections from the other patients in the room, down the hall, or next to them. Clients in healthcare settings often have multiple illnesses, are older adults, and are poorly nourished. Patients are more susceptible to infections. Many of our clients have a lowered resistance to microorganisms because of underlying medical conditions like diabetes, cancer, that impair their immune system. We also see within the hospital environment patients that have a lot of invasive treatment devices like IV catheters, Foley catheters, that predispose them to more infections because it's another opening into the body. Our invasive diagnostic exams are another example of why our patients in the hospital are higher risk for a nosocomial infection. We put tubes or tests down through them, bronchoscopies, gastroscopies, colonoscopies. All of those things then increase the risk of a nosocomial infection. When we look at a hospital-acquired infection, we see it's one that is present in a client when they're admitted to the healthcare facility. So a patient that comes in with pneumonia, that would be considered a community-acquired. Our risk for hospital-acquired infections then, here's a good list. As we look at those, think of the type of patients that would fall under those categories behind each bullet. Multiple illnesses, that's your diabetic that has pneumonia. When we look at our compromised immune system, we're thinking about people that have HIV, people that are run down, very malnourished. Maybe it's somebody that had bowel surgery and they have been NPO and not been able to eat for 3 weeks because that bowel is trying to heal, and nobody thought to start TPN or total parenteral nutrition. Use of poor aseptic technique, that is what we're going to learn in this unit, is how we as caregivers can provide very good aseptic technique in all the things we do. It will be every time we go into a patient's room, we look at what are we doing. Did we wash our hands? Are we using alcohol wipes to wipe off the catheter before we put the spigot back in the Foley catheter? Some of those very basic things in each unit, we will be talking about it. That's why our infection control unit comes so early within the curriculum. As we look at a hospitalized client, a common cause of a urinary tract infection in a hospitalized client would be poor hand hygiene, improper cath technique, uncontrolled hypertension, inadequate nutritional intake, or a nosocomial infection. A cause of a UTI would be number 2, improper catheterization. And with that indwelling catheter, maybe they touch something with their sterile gloves that they shouldn't have before they put the catheter in. Exogenous is not part of the normal body flora, and endogenous is part of the normal body flora we need to think about. Our medical asepsis is different than surgical. Medical is clean, and that is where we wash our hands. That's where I put a barrier or a towel down between the patient's arm and the bed when I start the IV. It's cleaning the environment. And our cleaning ladies, the cleaning staff in the hospital and in long-term care, have special training as to how to clean things so that we are getting all of the microorganisms off of all the surfaces. Many times it is a cleaning procedure where they go in and clean. They have to let it dry and sit for a period of time, and then they have to go in and do it again or have another step in that cleaning process. So our medical is clean technique. Surgical asepsis is a much higher level, it's much more expensive, and it's much more strict in what we do. These are sterile techniques that are used during client care, such as surgery. When I put a PICC line in, your patient that gets a special IV catheter called a PICC line, that would be a surgical type of asepsis where we are definitely wearing sterile gloves, getting the environment controlled in a way that we should have elimination of all microorganisms, including spores and other pathogens, from an object, and we're trying to protect that patient. Surgical asepsis requires more precautions than medical asepsis, and we know that a break in the technique can result in a contamination, and it leaves the client at risk for infection. Surgical asepsis, besides the OR, is very often practiced in your labor and delivery area where a woman is having a baby. And also many of our diagnostic labs are sterile technique or surgical technique because of the invasive nature for that. When we look at surgical instruments, our surgery nurses know that they have to put the surgical instruments in a basin and soak them. And after they soak and everything gets clean that way, then they are put through the autoclave, which is a very hot cooking of those to kill all of the microorganisms and spores. And then after they're autoclaved, they are wrapped and they are labeled with how long they're good for. And there's also a surgical tape in there, a special tape that says if moisture would get in there and contaminate it, that special tape in there will change colors. When we look at the operating room, there are a series of steps for the sterile technique. When we think about the operating room, we think of where it's located. And for many facilities, it's kind of tucked away by itself because we don't want a lot of traffic by in the hallway. We don't want the doors opening up to very heavily trafficked places because we don't want bugs and flies and mosquitoes getting in there. We don't want germs coming in. We don't want the average person walking by and being able to contaminate that. When we look at sterile technique in the operating room, they apply the mask, the eyewear, and the cap. They perform the surgical scrub, and then the sterile gown goes on, and then the sterile gloves are last. And you will be practicing that in basics. You have a whole actual unit on surgical and getting your patient ready for surgery. It's called the peri-op unit. In looking at preparing that sterile field, then we want to avoid any type of movement where we're going to lean over the sterile drapes. We don't want to touch anything in that sterile field that is going to contaminate that. So when we do some of our procedures that require a sterile field, you are going to, start by washing your hands and then gathering all of the supplies that you need, because once you start opening your sterile supplies, you can't leave them. You can't turn your back on them or leave them in any way because you have no guarantee of what happened to them when you were gone. So we look at certain sterile procedures, sometimes last for a long time, so it's important that we would look to see, what we have prepared. I think of OB. When you have a woman in labor, it's sometimes very difficult to tell, will she deliver in the next few minutes and I need to prepare my sterile field and get everything out for the physician that will deliver the baby? Or is this a woman that's going to be here a while, and if I open these sterile packs too early, I'm going to have to send them to be autoclaved again and go to the added expense of getting new equipment out. So that, in my idea, is sometimes very difficult as an OB nurse to judge how soon the delivery is going to take place in order to prepare the sterile field in a timely manner. When we look at a sterile asepsis, some of the principles are that something only remains sterile if it's touched by something that's sterile. So if your gloves are sterile, you can touch your hands together with the sterile gloves because they are both sterile. But if you would rub your eye and then touch your gloves together, you've now contaminated both gloves. You can only put it on a sterile field. And with that sterile object, like I said, if it is out of your sight, then it is considered not sterile anymore if it's below your waist. So everything has to be at waist level or higher in order for it to be considered sterile. The principles are listed in your book. There's a lot of them. We have to look at if it's questionable, if it's been contaminated, if you have a tear or a break in a covering of a sterile object, you discard it and assume that it's not sterile any longer. All items are properly sterilized before they are used, put in the package, and then again we look to see if the package was torn or wet. If it was opened and somebody decided they didn't need it and put it back on the shelf, it would be considered not sterile. Again, never turn your back on a sterile tray or leave it unattended, and any object below the waist is considered contaminated with that. And those are all just basic principles as we look at what we are doing in the surgical field for that. Moisture does seep through the sterile package's protective covering, and it allows the microorganisms to travel in with that liquid. When we look at microorganisms traveling through the air, they can fall in a sterile item, especially if we are reaching over our work area. So when we open up our packs, we're going to do it in a very controlled manner so that we are not leaning over our packs. And there's a picture coming up, I'll show you that. And then lastly, with our principles, we are looking again at the edges of a sterile field are considered contaminated, and the edges of 1 inch. So if I touch the outside edge of my sterile field, it's not considered sterile, and I haven't contaminated my field. So that 1 inch border around the sterile towel or drape is your considered contaminated area that we would never want to put supplies in that 1 inch area. After a sterile needle is removed from its protective cap, or after forceps are removed from the container, they cannot touch the edges of that field then. So as we look at the skill in the book, this is applying sterile gloves. As you can see that in the very first picture, she is touching with her unsterile hand the inside cusp of that. The glove is put on, it's kept over your sterile field, and then she uses her left hand, the sterile gloved hand, to reach in on the inside of the cuff, because that's where it's sterile, and remember, sterile has to touch sterile to remain sterile. Then you put the glove on, continuing to only touch the sterile or the outside part of that glove to get that on, and then you can put your fingers, lace them together to get the gloves repositioned and on snugly so they fit good and feel good. Our next slide is then opening the sterile package. The steps are listed in the book, but as you can see, she is opening the side furthest from her so that she is not leaning over. Then you open the two sides. Notice where her hand is on the second slide. It's underneath the drape, so she's not contaminating the top part. And then lastly, she opens the drape closest toward her. As we look at our assessment piece of the nursing process, we think of the risk factors for an infection and why we want to maintain sterile field and maintain infection control policies. We want to look at that client's susceptibility for infection, what is going on with that patient that we would anticipate that there may be changes to that. We look at factors such as lab results. What did they tell us when we interviewed them that maybe we're thinking they're high risk for an infectious process? And then we look at some of the cardinal signs and symptoms and put a star by that. Cardinal means very classic, or the signs we see. And for infections, they usually have a fever. They usually don't feel well. Their white blood cell count is elevated. And so we will be talking about those cardinal signs and symptoms a little bit more in part 3 of this infection control unit.